Welcome you all to this once a month statewide journal club of Tamil Nadu State under the leadership of Dr. Sabrin Ross and his executive committee of the Tamil Nadu State Chapter Indian Psychiatric Society, and also the committee members of the RCBC. This journal club is held every once a month on 3rd or 4th of every Saturday between 2:30 to 4:30. And this is my honor to introduce additional professor due for professorship, Dr. Sujit Kumar Kar, who is a psychiatrist come a researcher and from a prestigious King George Medical University, Lucknow. To briefly tell about TN IPS RCBC Journal Club statewide, we have invite one of the psychiatrists who is an academician and a researcher in anywhere from India, and we select one of his article published in a journal for discussion for our postgraduate students to learn about how to critically review or read a journal. And also we at the end of this journal, we also request our guest speaker to talk on a particular topic of interest for postgraduate students. Once a month journal club is attended by not only postgraduate students from all the medical colleges in Tamil Nadu, but also our practicing psychiatrists and senior psychiatrists in all over Tamil Nadu. In this current, we have selected nominated Dr. Sujit Kumar Kar as the guest speaker, and we have selected his article recently published in Asian Journal of Psychiatry titled Safety and Efficacy of Early Augmentation with a Transcranial Direct Current Stimulation in Adolescents with Major Depressive Disorder, a randomized controlled trial as an article. And this will be presented and discussed by Dr. Anusha M, who is a final year postgraduate student in psychiatry from Tanjavur Medical College, Tamil Nadu. And it will be moderated by Dr. G. Vanishri and Dr. S. Shankar. Following the general discussion, we have a guest talk with the topic Basics of Conducting Clinical Trial for Postgraduate Students. Apart from being additional professor of psychiatry, Dr. Sujit Kumar Kar is also a Vice Dean of Ethics, a researcher at KGMU, Lucknow. He has been a member of various associations, including a fellow of Indian Psychiatric Society. He is involved with various capacities with IPS, and also is a member of the ICAM. His research experience includes mainly in the area of non-invasive brain stimulation, neuropsychiatry, and suicide prevention. He has many achievements to his credit, including more than 500 plus research articles and 75 book chapters that he has authored. And he figured as a top 2% of the researchers, a word list prepared by Stanford University for the year 2021, 22, 22, 23, and 23, 24. He has won BBC Oration Award in 2023. This is just a glimpse of his many awards that he has won, and has given a talk at many symposia and then also in workshop. A few highlights of his research have been that he has been a PI, principal investigator from his side for a many multi-center funded studies. Notably are his involvement in the National Mental Survey done between 2015 and 16, and also magnitude of substance use disorder in India done during the year 2019. He is also currently a principal investigator at the site at Lucknow and from in the ongoing National Mental Survey Part 2. He is one of the highly cited author in psychiatry in the current times. His I10 and H index, which are considered as one of the researchers' achievement, stands at very high number at 116 and 42 respectively. His field of expertise are consultative lies in psychiatry and psychotherapy. Now I request Dr. Anusha M to present the article, and it will be moderated by Dr. G. Vanishri and Dr. Shankar. Over to Dr. M. Anusha.
Sir, good afternoon, ma'am. The article for today's discussion is Safety and Efficacy of Early Augmentation with Transcranial Direct Current Stimulation in Adolescents with Major Depressive Disorder, a randomized controlled trial. Authors of the study are Soumya Upadhyay, Vivek Agarwal, Amit Auria, Sujit Kumar Kar, belonging to Department of Psychiatry, King George Medical University, Lucknow, Uttar Pradesh, India. The journal was published in Asian Journal of Psychiatry in volume 103 in January 2025. Introduction. Depression is one of the most common mental illnesses worldwide. It is a leading cause of disability and a major contributor to the global burden of disease. According to WHO, 2.8% of teenagers aged between 15 and 19 years and 1.1% of adolescents aged 10 to 14 years experience depression. It is considered as a risk factor for substance addiction, school absences, academic underachievement, and suicidality. Transcranial direct current stimulation is an evolving non-invasive neuromodulation technique which is a safe and easily accessible alternative or adjunctive to other treatment modalities for disorders like depression, ADHD, addiction, and schizophrenia. It is associated with very few side effects like headache, abnormal sensations like tingling, burning, or pain at the application site, insomnia, and nausea. Almost all the side effects disappear with the termination of sessions. Depression has been associated with dysfunction in amygdala, hippocampus, anterior cingulate cortex, dorsolateral prefrontal cortex, and ventral striatum. Targeting dorsolateral prefrontal cortex, which is a prominent area of dysfunction due to its left hypofunction and right hyperfunction by neuromodulation techniques such as transcranial direct current stimulation, is expected to improve the outcomes. NICE guidelines recommends a stepped approach to treatment of adolescent depression, starting with psychotherapy or an SSRI, and then combining both in case of an adequate response. But both psychotherapy and SSRI have their own limitations, and options to overcome their limitations are yet to be explored. Transcranial direct current stimulation has been tried for treatment-resistant depressed patients, but its use and efficacy as an early augmenting agent is largely unexplored in children and adolescents. Early augmentation is expected to give early symptom reduction, giving better quality of life and early resumption of functioning. Objective of the study is to determine the safety and efficacy of transcranial direct current stimulation in adolescents with major depressive disorder as an early augmentation to drug therapy, thus hypothesizing that it will lead to a greater reduction in the depressive symptoms. Materials and methodology used. The study design is prospective, hospital-based, single-blind, randomized, parallel group, sham control study conducted at the Department of Psychiatry of a tertiary care teaching hospital in North India. The protocol was approved by the Institutional Ethics Committee, and the trial was registered in the Clinical Trials Registry in India, and the registration number was obtained. Patients were recruited over a year from October 2022 to October 2023 with follow-ups till February 2024. Adolescents in the age group of 10 to 18 years suffering from major depressive disorder and who were drug-free for the past 1 month were included after taking consent from parents and assent from the patient. Treatment-resistant psychotic depression, suicidality, medical comorbidities, contraindications to tDCS, any other psychiatric comorbidities except tobacco are excluded. Randomization and blinding. The sample size was calculated as 44 through priori analysis using the G-power statistical power analysis application. The effect size was taken as 0.25 and power as 0.95, and the final sample estimated was 53. Purposive sampling with random allocation of subjects into two groups in a ratio of 1:1 using computerized random table method was done. Group allocations was not disclosed to the participants to ensure blinding, and computer-generated random sequence number in opaque sealed envelopes. Protocol used for transcranial direct current stimulation. The anode was placed at the left dorsolateral prefrontal cortex, the cathode at the right dorsolateral prefrontal cortex. Under the traditional method of 5 cm method, the DLPFC was located to be around 5 cm lateral and anterior to the vertex. Patients in the active group received 2 milliampere current with a ramp time of 20 seconds for 20 minutes. Patients in the sham group received a short period of stimulation followed by ramping down to no current for 20 minutes. Patients in both groups remained on stable doses of tablets sertraline during the study period. Total of 142 patients were assessed and 104 were excluded, out of which 30 patients declined to participate due to logistic issues and 74 did not meet the inclusion criteria. Out of 38 patients who were randomized, 18 were placed in the two transcranial direct current stimulation and 20 in the sham group. Three were excluded in each group due to non-completion of sessions. 5 patients dropped out and withdrew their consent from the study. 1 patient switched to mania. 32 patients were analyzed with 15 in the group and 17 in the sham group for 2 weeks and 6 weeks. 3 patients with loss of follow-up at 6 weeks were analyzed with last observation carry-forward approach. A total of 2 patients, 1 in two group and 1 in the sham group, were previously treated with antidepressants. Assessment. Demographic characteristics were recorded at baseline. TD schedule for affective disorders and schizophrenia presented lifetime scales were administered to diagnose cases and to rule out other psychiatric illnesses. Depression inventory scale was used to assess depression, and anxiety inventory scale was used for anxiety. Executive interview 25, that is exit 25, was applied for assessing cognition. Both the groups received a total of 10 sessions over 2 weeks. Transcranial direct current stimulation side effects checklist was applied after every session. All the patients were assessed at the baseline at the end of 2 weeks. Third and final assessment was done after 6 weeks using the same scales. The BDI and DIA scales are self-rated and may prevent investigator bias. Analysis. Data was analyzed using the computer software program SPSS version 24. Sample characteristics were analyzed with descriptive statistics. Normalcy of distribution was checked with Kolmogorov-Smirnov test and data was found to be non-normal. Continuous variables were compared with Mann-Whitney U-test and categorical variables were compared with Fisher's exact test. Mann-Whitney U-test was used for the between group comparison of the scores. Mean reduction in the scores of the two groups with respect to time were compared. Post-hoc analysis was done to see within group interactions with respect to time using the Wilcoxon signed rank test for repeated measures for both groups. Cohen's T was estimated for the effect size. Results. No significant difference in socio-demographic variables between two groups were found. In 2 weeks of assessment, after giving 10 sessions of transcranial direct current stimulation as an augmentation, a significant difference in the BDI scores of the two groups was found. The BDI scores of both the groups followed a reducing trend at 2 weeks, with the scores of the two groups showing statistically greater reduction than the sham group. At 6 weeks of the baseline assessment, that is 4 weeks post-intervention, the significance, however, did not persist. On BIA score, similar results were found. 2 weeks scores were statistically significantly lower in two groups. Between the two groups, the average of BDI and BIA score baseline had insignificant difference. At 2 weeks, the difference in mean scores of each group was significant, but at 6 weeks, the difference was insignificant again. Between the two groups, the average of exit 25 scores had no significant difference at baseline, 2 weeks, and 6 weeks. The reduction in the BDI scores was significantly higher in the two groups from baseline to 2 weeks and from baseline to 6 weeks. However, reduction was similar in the two groups between 2 weeks and 6 weeks. Difference of BDI scores in baseline versus 2 weeks, baseline versus 4 weeks, and 2 weeks versus 4 weeks is statistically significant in the two groups. The BDI scores gradually decreased significantly until the last follow-up in the two groups. At 2 weeks, no patient showed response or remission, but at 6 weeks, 53% of patients showed response in two group and 20% showed response in the sham. Cohen's T was estimated for quantifying the effect size, and the effect size at 2 weeks was found to be large, and at 6 weeks, the effect size was found to be moderate. Number to be treated at 6 weeks, considering a response as a good outcome, and the absolute risk reduction to be 35%. It was observed that in every 3 patients, 1 will be benefited from the intervention. And for the remission, we're taking the absolute risk reduction as 8% and number to be treated as 12.5. 1 in every 10 patients would be benefited from the intervention. No serious adverse effects were observed during the study. The most commonly reported side effects in the two group were burning, headache, numbness, and pain. Sertraline was started on the day of first session. The mean dose of sertraline was similar across both the groups. The mean daily dose of clonazepam was significantly higher in the two groups than in the sham group at 2 weeks and at 6 weeks. The estimated sample size was 44, giving the power of the study as 95% and considering 20% of dropouts. Intention was to recruit 53 patients, but only 38 patients could be recruited. Intention to test included a sample of 32, which resulted in fall in the power of the study to 85%, but still it was within the acceptable limit. Discussion. The change in cortical excitability induced by depolarization of the resting membrane and long-term potentiation by induction of synaptic plasticity is the proposed mechanism of transcranial direct current stimulation. Fluoxetine and escitalopram are commonly recommended for the treatment of depression in pediatric population. However, sertraline is also considered as a safe and effective antidepressant in pediatric depression. There was statistically significant difference in the BDI scores of two groups at 2 weeks and 4 weeks after the baseline assessment. At 6 weeks after the baseline assessment, the significance did not persist. Approximation of the group scores could be due to the lag period before onset of effects of SSRIs, which is often reported to be around 2 weeks. On the BIA scores, the 2-week scores were statistically significant, slower in true group. The significantly higher usage of mean dose of anti-anxiety drug known as a pump for 2 weeks could have influenced the effect of BIA scores. No significant differences were observed in cognitive functioning between the two groups as a result of transcranial direct current stimulation. Transcranial direct current stimulation was not found to influence the overall score after cessation of sessions, as the total reduction was significantly greater in the two group even at 6 weeks. The differences in the scores at the 3 points is significant in both the groups according to the post-hoc analysis. Considering a response as a 50% reduction in the BDI scores and remission as a score of 9 or less, in line with the previous studies, at 2 weeks, neither groups showed any responders. At 6 weeks, 53% of patients had responded in the true group and 18% in the sham group. 20% of the patient had achieved remission in the true group and 12% in the sham group. The statistically insignificant finding was attributable to smaller active group and the differences in the age group. The expected sample size could not be achieved. It may be due to the guardian's hesitation to try a neuromodulation method, especially as an early treatment strategy instead of conventional medications. Children are less likely to cooperate with neuromodulation methods like RTMS, as they are generally more restless than adults. Transcranial direct current stimulation was found to be easy to administer, and the children were cooperative with repeated administrations. Limitations. Single blinding may have led to investigator bias. The scale used to assess depressive symptoms was subjective. There was a possibility of a blind break as blinding checks were not performed. The group receiving active transcranial direct current stimulation received a relatively higher dose of benzodiazepines than the group receiving sham. The inclusion of only treatment-free patients and exclusion of patients with resistant and psychotic depression would have influenced the outcome. The patient group was largely of moderate severity of depression. The outcome cannot be solely attributed to transcranial direct current stimulation, as the patients were also receiving antidepressants and benzodiazepines. Larger sample sizes and longer follow-ups are needed to make more informed treatment choices. The results cannot be generalized to all spectrums and severity of depressive symptoms due to the single symptom nature of the study. The long-term effects remain uncertain and warrant further investigation for more informed decision-making. Conclusion. The study is first of its kind globally exploring into the effects of transcranial direct current stimulation as an early augmentation in the adolescent depression. It is a pioneering work with a significant step forward in understanding of adolescent mental health treatments. Transcranial direct current stimulation is safe to use in the adolescent population and shows efficacy in adolescent depression as an early augmentation to drug treatment. The study convincingly established the safety of transcranial direct current stimulation in the adolescents, which is a significant groundwork for further research. Its long-term utility remains debatable and needs further research. Larger sample size, adding the number of sessions, or giving booster sessions, or increasing the duration can be targeted for future research. Declaration of conflicting interest. The authors declared no potential conflicts of interest with respect to research, authorship, or publication of this article. No funding was done in this article. Critical appraisal. Strengths of the study. The study is a RCT and has been registered. Neuromodulation technique in adolescent age group has been studied. Self-rated scales has been used. Outcomes have been studied in 2 weeks and in 6 weeks. So expected sample size was not achieved. It was not statistically significant. Limitations. It is a single blind study. Generalization of the study is not possible. Antidepressant and benzodiazepines are concurrently used. Only moderate severity of depression was in the sample. Consort checklist for the article. Structured summary of trial design, methods, and conclusions were mentioned in the title and the abstract. Scientific background, rational explanation, specific objectives were given in introduction. In methodology, trial design and allocation methods, eligibility criteria, setting of the study, details about interventions, outcomes, determination of sample size, method for random allocations, and steps for concealment, blinding. Statistical methods used were mentioned and discussed. In results, concept flow chart for participants was given. Dates of recruitment and follow-up was mentioned. Baseline demographic and clinical characteristics was given and compared. Results for each group and estimated effect size was discussed. Side effects resulted during the study was mentioned. Discussion, trial limitation, potential bias, generalizability, interpretations consistent with the results and other relevant evidence was discussed. Registration done in clinical trial registry in India and trial registration are mentioned. Sources of funding disclosed. Thank you, sir. Thank you.
Wonderful presentation, Dr. Dr. Anasuya.
So, majority of the things that we have discussed already in this discussion segment, basically I'm trying to focus more about, because this is a clinical trial and many postgraduate students, they conduct a clinical trial or randomized clinical study during their postgraduate thesis. So what things they need to know when they are doing a clinical trial, or in the due course of time during the early career or the late career, they are interested in doing a clinical trial, what are the things they need to know? This is the focus of my presentation. Coming to the index study that we have discussed, that it is safety and efficacy of early augmentation in transcranial direct current stimulation in adolescents with major depressive disorder, a randomized control study. So what is uniqueness in this study? In this study, we use neuromodulation for adolescent depression. When you are looking for neuromodulation related studies or most of the interventional studies, the studies are mostly limited to adult population. In the exclusion criteria, they exclude patients with special population, pregnancy, lactation, elderly individuals, pediatric population. They are mostly excluded from the studies. Mostly people take more than 18 years age up to 60, 65 years of age. So adult population is the population that mostly studied for any innovative intervention or neuromodulation intervention or any majority of the interventional studies. Here we used neuromodulation for adolescent depression, which is not commonly studied population. So that gives a uniqueness to this study. Second is the protocol safety in adolescent population. Rightly pointed out by Dr. Sivanand during the discussion session that we don't know that adolescent population, the growing age, the developing brain, what will be the impact of a intervention, which is a newly emerging intervention that is being delivered to that population. There might be some unwanted effect or the adverse effect, which might be crippling for the patient. So it is important to establish the safety of that intervention in the specific population. Then the third new thing in this study is use of neuromodulation as early augmentation strategy. Conventionally, neuromodulation like tDCS or TMS, they are recommended for treatment of depression, particularly in patients who are having a resistant depression, those who are having a treatment refractoriness, those who are adequately tried with a trial of antidepressants with minimal improvement or partial response. So that is fairly well-known condition that somebody is not responding to the conventional treatment. You are trying with the innovative treatment. But as an early augmentation strategy, this is something very new concept that is being used for treatment here. So let me discuss about the new concept that is early augmentation. So as we have already discussed that conventionally augmentation is introduced late in the course of treatment. People initially try with when they are treating a depressive episode, they try with the antidepressant. Then they optimize the dose depending upon the response. If there is no response, then they switch to another antidepressant, maybe of the same category, but sometimes of the different category. If you are trying with the SSRI initially, you can try with the serotonergic and noradrenergic medication in the subsequent trial. So switching to another antidepressant, still there is no response, then you think of treatment augmentation. Either if you are treating a depressive episode, people try augmentation with pharmacological augmentation with low dose antipsychotic like risperidone, aripiprazole, thyroxine, lithium, buspirone, and so on. And sometimes with stimulants like modafinil or modafinil methylphenidate is also being used. In fact, I'll say that the early augmentation experiment in depression was initially done with stimulant. The first study that discussed early augmentation strategy was a case report. I remember it published somewhere in 1997 or 98. They did intervention. One group received sertraline, other group received sertraline with methylphenidate. And they found that those who received sertraline with methylphenidate, they responded quite well to the treatment, and there is an early reduction of the symptoms and better early resumption of the functioning. So from there, the early augmentation concept started. So conventionally, after a treatment augmentation, people think of considering combining treatments. But early augmentation is something that is being introduced early in the course of treatment. So who are those patients who actually require augmentation? Those who are good responder to the antidepressant treatment, they will actually not require. They can continue with the same antidepressant, or dose optimization is enough for them. That happens with majority of the patients. But there are some patients who remain partial responder or poor to non-responder. They will require treatment augmentation. So it's a early augmentation is basically referring to introducing a augmentation strategy early in the course of treatment. Regarding this study, there are some strength and weaknesses that has been already been discussed. Something related to the study design, that is, it's a randomized control study. Randomized control trial is considered to be one of the trial which is having a highest level of evidence among the clinical interventional studies. Some control is being taken. Standardized intervention strategy has been used like antidepressant like sertraline and tDCS, and the common site that is DLPFC is the standard site that is being used. Standardized rating scales like Beck Depression Inventory, Vex Anxiety Inventory, Exit 25, they are being used. There is improvement in 2 weeks that we got. Side effects are comparable. These are some unique features that we got. The limitations being small sample, details of blinding. Actually, when you are reporting a randomized clinical trial, you are supposed to explicitly mention everything that you have followed in the trial. You should not leave anything for the assumption of the readers. So everything need to be documented. If you have not documented, then it is assumed that probably it is not done. So though the study procedure mentions that single blinding is done, but how the blinding is done and who was blinded, that was not explicitly mentioned in the study. So that becomes a limitation. So when I read my own article, later on we realize that these are the things that need to be taken care. We are all different phases of learning. So we are doing the things and we are learning from our own mistakes. That we have already discussed, that self-reported scales, they have lack of objectivity. That can be limitation of majority of the psychiatric studies where they use only self-reported scales, and sometimes you use scales that only quantify the change in the symptom profile, that is symptom reduction. But symptom reduction is not always equivalent to functional improvement. So it is always better to look for a scale that gives an idea about functional changes, like disability related scales, global functioning related scales, subjective well-being related scales. So these are the things that actually gives an idea about what is the global improvement in the functioning, disability and overall well-being. So we have not used that, but for the research, if people they will use it, they can have a better understanding regarding the findings of the study. Small sample always limits the generalizability, particularly because this study is in a narrow age range of 10 to 18 years of age, adolescent population. You can uh, try to extrapolate the findings to a adolescent population, but it cannot be extrapolated to pediatric population, cannot be extrapolated to geriatric and other special age of population, because the benefit is transient and goes up by 6 weeks. Maybe a longer follow-up will give an idea about what is happening in the due course of time. That is not there with the study, because this is a part of the postgraduate thesis, and it is not possible to do a long-term follow-up in a postgraduate thesis. That's why it was not possible in the study. However, if it is a investigator-initiated research or a funded research, definitely having a long-term follow-up will definitely give a better idea what is happening in the course of after tDCS, after neuromodulation intervention. This is all about this study. Now we can talk about some brief overview of clinical trial. I will simply discuss about what is clinical trial, why clinical trial is important, how a clinical trial need to be done, and what are the guidelines to be followed, and when a clinical trial need to be started, when it need to be aborted. So these are the brief things that we are going to discuss over next 10 to 15 minutes. So we all know that randomized clinical trial is one of the highest level of evidence, generates a highest level of evidence among the clinical studies, and it is a type of interventional study. There are other types of interventional studies, non-randomized trials, open label trials, adaptive trials, but randomized control trial is a very specifically designed clinical trial which gives a more reliable evidence. So what are the different types of clinical trials and what are different phases of clinical trial? It is important to understand. Clinical trial is basically a research that studies the new test and treatment and evaluates their effect on a human health outcomes. The health outcome can be a positive component, that is efficacy, and can be a negative part, that is side effects. So safety and efficacy are the two major parameters on which a clinical trial outcomes are evaluated. Other things are when you are doing a clinical trial, you also look for feasibility, whether it is feasible to do a study by do a such type of interventional study. When we did this study in the adolescent population in the as a early augmentation strategy, some of the participant has rightly pointed out what are the challenges that you have faced when you were obtaining consent for this study. So this is more of when you are doing a study and doing a early augmentation kind of thing, then people are quite reluctant and hesitant to give consent for a innovative or a newer intervention. They always believe on the traditional modality of treatment, like let's go with a pharmacological treatment. If there is no response, then we'll think of a trial like tDCS. In the initial phase, now the patient has not received any treatment, will not go for tDCS on the very beginning. So this is how the parents and student and the participant were reluctant. So feasibility becomes an issue. So sometimes you may face difficulty in getting the adequate number of sample if it is a time-bound study. So you need to be cautious whether it is feasible to get the adequate number of patients, whether it is feasible to get adequate number of adolescent depression patients in your setting. So accordingly, you have to plan. If you have a specialty clinic, adequate number of patients are coming and patients are convinced and they are sensitized enough about the newer neuromodulation or newer intervention strategy, then you can think of completing the trial in time-bound study. So feasibility is important. There are many clinical trials, they give an idea about the feasibility. Safety and effectiveness is the primary aim of majority of the clinical trials, whether the intervention is going to be effective or not, and how safe is that intervention. So safety and effectiveness. Then whether the intervention is superior to the existing standard treatment of care, that is superiority, and how precisely the intervention is going to help in symptom. Whether the many people, they have rightly pointed out whether the intervention is only doing reduction of the depressive symptoms, or it is additionally doing improvement in the anxiety symptom, cognitive symptom, suicidal behavior. These are the things, because all these things are interrelated. Is this information, is this intervention is very precise or accurate or targeted intervention for a particular group of symptoms, or it is a spectrum of symptoms? So accuracy related to symptoms is again one thing. Somewhere in 2017 there is an article, predictors of response to TMS. You can read that article, that is published in Clinical Psychopharmacology and Neurosciences. This article is basically about from the clinical characteristics, can you predict that which clinical characteristics are likely to improve after a neuromodulation intervention, and which type of symptoms are relatively refractory to a neuromodulation intervention. Can those type of symptoms be a predictor of response to that intervention? Clinical trial can be done for checking the utility of drugs. There are some biological products, cellular products, devices, surgical procedures, radiological procedures, psychological treatment, preventive positive lifestyle measures. All this can be a part of clinical trial. Many people, they say that many students, they do some lifestyle related interventions, like because I am the dean of ethics committee, vice dean of ethics committee in my institute. When students submit their proposals, I review their proposals. I see that they did lifestyle related modification and its impact on metabolic syndrome. So when you are doing, and they see that it is an observational study. No, it's an observational study. When you are doing a lifestyle modification as an intended modality of treatment, and you are comparing it, those who are not doing lifestyle modification, then it's a clinical trial. It's a lifestyle related modification, is a form of intervention to check for the change in the metabolic syndrome. It cannot be observational study. If somebody is doing lifestyle related modifications, it is not part of your study, you are just observing what is happening, then you can say it's a observational study. So don't think that clinical trial only refers to interventions related to a drug or a electroconvulsive therapy or a neuromodulation like TMS or tDCS. It can be related to other measures as well. Now, who can be a part of clinical trial? Ideally, to remain in a safer side, if the safety is a matter of concern, if you are trying with a new intervention, then ideally to do it in an adult population. But if the safety is completely ensured and the intervention is tried previously with other groups of population, then you can include all age group of population, including children. Is it another important question? Many researchers, they think, is it necessary to register a clinical trial? Initially, it was suggested that clinical trial need to be registered. It's not mandatory thing, but it is a preferred thing. It is better to go for registering the clinical trials. But nowadays, it has been made mandatory by many institutions and many international bodies. If you are going for a clinical trial, you should register it under a particular clinical trial registry. So it is a scientific, ethical, and moral responsibility to do the registration of the interventional study. So another question is, suppose somebody has conducted a clinical trial but not registered it, and they have already started recruiting the patients after taking a ethical approval. Is it possible to do the registry in the clinical trial? So there are some provisions. In retrospect, you can do the registration in the clinical trial registry, but there are many clinical trial registries, they don't allow for retrospective registrations. Previously, the Clinical Trial Registry of India was allowing to do a retrospective registration. Very recently, they have closed that option of retrospective registration. Only you can register the clinical trial prospectively. So you got a ethical approval from your institute, then you submit it for Clinical Trial Registry of India at least, and you will get a approval registration number. And once that approval number you got from the clinical trial registry, then you can start recruiting patients. And during that, you need to ensure by replying a mail to the clinical trial registry of India that you have not recruited any patient till getting the clinical trial registry. Only after getting the clinical trial registry will be recruiting the patient. This is the new mandate by the Clinical Trial Registry of India. So Clinical Trial Registry of India is something that is being sponsored by the Indian Institute of Medical Statistics, which is a branch of Indian Council of Medical Research. And international agencies, they like US National Library of Medicine, they have their clinical trials gov. That is, you can register your trial with Clinical Trial Registry India. You can register your trial with Clinical Trial of US, but it is better to do with your, it is difficult to do the registration with US National Library of Medicine, because they have a very strict mandate for doing the registry of clinical trials. So it is easy to do it in the Indian Trial Registry. Many countries, they have their own country specific, like Iran, they have their own clinical trial registry. China, they have their own clinical trial registry. UK, they have their own clinical trial registry. So the country specific research, they are registered in those clinical trial registry. But there are many countries, they don't have clinical registry of their for their own country. So if the countries like Afghanistan, Bangladesh, Nepal, Bhutan, they don't have their own clinical trial registry. If somebody is pursuing a clinical trial in those countries, they can apply for registration in Clinical Trial Registry of India and Clinical Trial Registry of US. So there is a provision that is open by the Indian government to do facilitate research and clinical trials in the region, not only limited to India, in the South Asia region. So other countries where clinical trial registry is not available, those people, they can also register with Clinical Trial Registry India. Now it is important to understand different phases of clinical trial. I will be quickly skipping this slide. We all know that there are preclinical studies. You want to check if there is any measure drug toxicity. You are planning to understand the pharmacokinetics and pharmacodynamics. We need to do some experimental animal related studies, and you need to choose an animal which is having a similar pharmacokinetics characteristics just like a human. So commonly chosen animals are sheep, mouse, monkey, guinea pig. These are the commonly chosen experimental animals. So you need to have an experimental animal lab where you can conduct those things. They are preclinical studies. But for clinical study goes through four different phases. Phase one is to look for the pharmacokinetics in a human population, pharmacodynamics in a human population, and look for the safety in a healthy population. Then phase two is meant for conducting a study to look for the adverse effect in a patient population and to compare it with the placebo, and to look for the preliminary therapeutic benefit in comparison to placebo. Then large randomized control trial comes to the phase three. You can do it in the multiple centers. It gives more of an idea about the efficacy and short-term and long-term side effect of the intervention. After the phase 3, the concerned company or can apply it for approval from the concerned drug approval agencies. Like US FDA approval is required for the American uh, for American drug industry, and those people, those who want to introduce a medication or intervention in US and related states, they need to get the US FDA approval. Similarly, there is a approving agency in European approval agency. In India, we have our own approving agency. One of the approving agencies, CDSCO. I'm going to discuss about CDSCO in subsequent slides. After getting the approval from the concerned agency, then for that post approval marketing, now it is targeting a larger audience, more of multiple center clinical trial, so that it can be you can look for the long term efficacy and long term side effect. So that can be ensured through the phase 4 trial. So here I will say that you might have noticed that many of the drugs that were tried during the COVID-19 pandemic, even the vaccines, they went through phase 1, phase 2, phase 3 trials. Even many of these things, the phase 3 trials were highly questionable because despite of very small sample, despite of limited number of organizations, because it was a life-threatening situation and it was a global pandemic, the approval was given, benefit of doubt to many of the antiviral agents for use, and even the vaccines for use for the general population. So that was very premature decision. It was highly criticized by many international agencies. Now, clinical trial, why we need to conduct a clinical trial? Clinical trial basically guide evidence-based practice of medicine. What type of medication, what type of intervention is most effective, what is superior, what is most safe intervention, what is the long-term safety, what is the long-term efficacy. All these informations you will get only after conducting a properly designed clinical trial. That's why clinical trials, they give evidence, and these evidences, they influence the practice of medicine. So safety practice of, for a good clinical practice, we need to refer to the adequately or properly designed randomized clinical trials. There are some biases that we need to consider or address while conducting the clinical trials. Many people, when they do a clinical trial, they try to report the positive findings. Negative findings or equivocal results are not properly documented. I was just going through a study that was using transcranial random noise stimulation in the management of tinnitus. What they did, they initially planned to use transcranial random noise stimulation for the treatment of tinnitus to change in the severity of tinnitus. There were some secondary outcomes like change in the behavior in terms of irritability, subjective distress, and impulsivity. They didn't found at the end of the study. They didn't find any improvement in the domain of severity of tinnitus. But they reported that there is improvement in the subjective distress. They also reported that there is reduction in the impulsivity. Now they published an article. That article is basically patients with tinnitus, when you do transcranial random noise stimulation, there is improvement in impulsivity and subjective distress, which was the secondary outcome. That was a positive finding in that study that was reported. But the major negative finding was, the primary objective was to look for the change in the severity of tinnitus. They had not reported that. So this happens. People don't report about the negative findings or equivocal findings, but they purposefully submit the positive findings, and that increases the chances of publication. Selective reporting of positive findings. Many people, they conduct a trial, but they don't publish it. So when you do a systematic review or meta-analysis, you will not find the details of those studies. So there is a bias in the reporting of the data. In many instances, will not get the data set, the raw data set, there is non-existence of research data. Many people, they started a trial, they did an interim analysis, initially published a report, and in the due course of time, they have not completed the trial, or they have abandoned the trial because of some adverse consequences. One of the reason during the COVID period was the funding was interrupted because of the COVID-19. The funding was diverted towards something, and because of the COVID-19, the recruitment of patients were not possible. So many trials were abandoned or terminated prematurely because of the prolonged COVID pandemic. So now the data related to those trials were not available. So there is missing data, so that results in publication biases. Now the thing is, when to do a clinical trial. Suppose you are thinking with some subjective evidence that this modality of treatment is going to help for a particular condition, and there is a theoretical background, there are some early evidences. Now you want to generate evidence by testing your hypothesis. So you need to do a clinical trial. But when you report that there are some major glitches in the trial, there are some major side effects, life-threatening side effects that are coming, or some serious consequences that are happening, it is important to stop the trial. It is important to inform it to the concerned authority and stop the trial. Sample size estimation is highly important in a clinical trial. So it is important to know how much is too much, how much is actually basic required to have a adequate sample size. So for estimating the sample size, you need to have the idea about what are the type 1 error you need to consider. Usually the probability we usually take for a biomedical research is 5%, it is 0.05. Type 2 error you need to consider the effect size, number of groups that you are taking, and the number of assessments that you are going to do. In this study that we have done and today it is presented, we have done 3 assessments. One is a baseline assessment, a second assessment is at the end of 2 weeks, and the third assessment is at the end of 6 weeks. So this is a 3-point assessment, but there are many studies people do multiple time points of assessment. So accordingly, the sample size will vary. Here, the comparison group is true versus active tDCS versus SAM tDCS. But there are many studies, they use multiple groups, like they tried with active tDCS, other group they tried with TMS, the third group they took SAM tDCS, and the fourth group they took SAM TMS. So now they have taken 4 groups. So this is how you can do the number of groups. The number of groups, they also influence the sample size. The more the number of groups, the sample size for each group will be less. More will be the number of assessments, the sample size will be less. Now, can we change the level of significance in a clinical trial? Or is it mandatory to keep it fixed at 0.05? Most of the clinical trials, they keep the significance value that is at 5%, that is 0.05. But many clinical trials, particularly when it is related to a very game changer intervention like life-threatening situation, so they change the significance. They want to be absolute surety about the evidence. So they change the p-value. Like suppose you are designing a new drug or a new intervention or a new pacemaker that is for treatment of ventricular tachycardia or atrial fibrillation, which can be a life-threatening situation. So in that scenario, you cannot afford a probability of 5%. You need to minimize the probability so that you can have a better level of evidence. Now it is life and death situation. So you can change the probability to 1%, that is 0.01. Power of the study is important determinant in deciding the clinical trials and estimating the sample size and judging the outcome of the clinical trials. So it is an acceptable limit of the power of the study is at least it should be 80%. In the current study that is discussed today, While estimating the sample size, the power of the study was kept 95%, which is a very good power of the study. And the sample size estimated keeping the power of the study 95% was 44 with a dropout rate of 20%, leading to a final sample size of 53, but could not reach that target because of a refusal to participate in the study, leading to an ultimate sample size of 35. So that is declining the power of the study. But despite of that, the power of the study declined from 95 to 85, which is still more than 80%, which gives a reliable outcome of the study. So it should not. So when you are estimating the sample size, try to take a power of the study in a relatively higher range, so that even if the sample size, you are not able to reach the sample size, even if the sample size falls, but still you will be able to manage to some extent by the power of the study. But if we have calculated the sample size by 32, keeping the 85% power of the study, and during the time of recruitment we reach a sample size of 28, so that study will be underpowered. So that will reach a power below 80%. So underpower study is subject to more of a biased findings. You cannot generalize it. So effect size is something important in clinical trials. It is a statistical measure that can be used to compare the efficacy of different agents. Here we use tDCS active form versus tDCS sham form. So what is the difference in terms of their outcomes? So large treatment effect is around 30 to 50% reduction of the symptoms. That is, effect size can be calculated by using two statistical parameters. One is Cohen's d and other is Hedges g. So up to 0.3 is a small effect size, 0.3 to 0.6 is moderate effect size, more than 0.6 is large effect size. Many studies, they also refer that 0.8 and beyond is a large effect size. Now, when you are doing a clinical trial, you need to think that whether it's what type of trial it is, whether it's a superiority trial, non-inferiority trial, whether it is intended to just look for efficacy and safety, and whether you are doing a blinding or not, what need to be done. So there are some guideline recommendation how to do that. When you are recruiting to the placebo arm, to the sham arm, to the no treatment arm, when you are taking a control who is receiving another dose of medication, when you are taking a control which is taking a active intervention, what should be the sample size? So there is a norm. This is available. You can refer to it. I have shared my publication. I am not going to the details of it, but I am just want to highlight that these parameters are important. When it totally depends upon the type of control, what will be the superiority, what will be the non-inferiority parameter, what will be the sample size. When you are taking the placebo control trial, so ideally try to take a relatively smaller sample size and try to recruit more number of relatively patients in the active arm than the placebo arm. Usually people take 2:1 for the active versus placebo arm. But our study, we took 1:1. So, but you can, because the other arm, they are actually not receiving placebo. They were also receiving antidepressant like sertraline. Just the add-on treatment was placebo. Add-on tDCS was sham tDCS. That's why we took 1:1 ratio. But suppose you are doing an intervention where you are giving sertraline to one group and B complex to the other group. So try to take 10% in the placebo group and 20% in the active group. If you are taking a sample of 30 with a ratio of 2:1. And now something important to know, it is always not possible to do a randomized control trial because randomization requires a specified expertise for doing that. You can do a simple open level trial is a relatively much easier way of doing it. You are giving escitalopram, you are aware of that, what you are giving, what dose you are giving, and the patient is also aware of it. So there is no blinding. And you are looking for the change in the parameters of depression. So this is a open label trial. Suppose you are giving a newer antipsychotic or newer antidepressant, and you are looking for the change of the depressive symptom. That is an open label trial. Open label trial can be with a control arm, can be without a control arm. But randomized control trial is a more delicate and more reliable research design that requires randomization, that require a control group, that require a specific intervention. Then you may go for blinding, or you may then something that is more required before the blinding and randomization is allocation concealment. Somebody who is allocating the or recruiting the patient is not aware to which group the patient is going and what is the subsequent patient to which the patient is going. So allocation concealment. When you are publishing or doing a clinical trial or submitting it for clinical trial registry, they will ask for the details of randomization, details of control, details of intervention, blinding, and allocation concealment. So be prepared about all these things before submitting a trial to ethical approval, before submitting a trial for clinical trial registry, and before submitting a protocol for publication or a research finding for publication. They will require all these things. These are mandatory requirements. There are some pragmatic clinical trials. They basically determine the risk, benefit, and the cost effectiveness of an intervention. So pragmatic intervention, it is very difficult to do for a postgraduate thesis. It requires a larger population, multiple centers, and a longer duration of study. There are some clinical trials that are called as crossover trials. It is important to know what is a crossover trial. Suppose you did a randomization, you assigned a group A and group B. One type of intervention is given in group A, another type of intervention is in group B. And you did this intervention for, let's assume for 4 weeks. After that, you allow a washout period. Then washout period is meant for taking out the effect of that intervention that you have already given. Now you have given the intervention B to the group A and intervention A to the group B. Now there is a crossover after that washout period. So this is a crossover trial. Another way of doing the crossover trial is without washout period. You can directly switch from, you start, one group received ECT, other group received antidepressant. After a period of 2 weeks, those who received ECT, they will go to the antidepressant group. They will receive antidepressant. Those who received antidepressant will be stopped and they will go to the ECT group. So this is again a crossover trial. So there are various ways of crossover. Sometimes you can plan the crossover. Sometimes it is happening unplanned manner. Like you thought of starting the treatment that you will go, there will not be any crossover. That is a parallel design. But at the end of 4 to 6 weeks, you realize that it is wiser to do a crossover to see the efficacy. Then you change the design and amended the protocol and you planned for a crossover trial. That can also be done. Then blinding is something important in a clinical trial. Open label trial, there is no blinding, but there is single blind. The blind can be the patient. Sometimes you cannot do the blinding in the level of patient. Suppose you are doing psychotherapy to the patient and pharmacotherapy in other patient. You cannot make the blinding because psychotherapy is given. It's a different modality of treatment. Suppose you are doing a head-to-head trial with ECT versus antidepressant. You cannot do blinding to the patient because who is receiving the ECT, they will be definitely knowing that that is a different type of intervention. But you can do the blinding at the level of analyst. The analyst will not ask about what type of intervention happened. Analyst will only do the assessment of BDNF. They will take the blood sample, they will check the BDNF level. They will apply the Hamdi scale, they will apply a cognition related rating scale. So analyst is not aware of to which group the patient is belonging. Here the analyst is blind. So it can be a single blind. where the analyst can be blind or the patient can be blind. Only one group is blinded to the intervention. It can be a double blind, which is a relatively better idea, where the patient is not aware, the person who is doing the intervention is not aware. So it's more of double blind. It can be triple blind. The analyst is also not aware, patient is not aware, and the person who is doing an intervention is not aware. All the three levels. So the more the blinding you do, you minimize the possibility of rater bias, patient related bias, reporting related bias, intervention related bias. All these factors you can minimize. So biases in clinical trial can happen before conducting the trial as well, like there, because of the erratic research design, because of the sampling bias. Sometimes during the trial, it can be because of the recall bias, because of the assessment measurement related issues, publication related. Selectively you are reporting something, so publication bias may happen. Selectively reporting the positive findings only, you are hiding the negative findings or adverse effect, so reporting bias may happen. So these are all the things that may interfere with the outcome. So when you are doing a clinical trial, refer to the Equator network. There is a guideline for each of the type of studies. For the randomized trials, there is a guideline called as Consort guideline. There is a checklist that you refer to that. And so Consort checklist is 2010 version of checklist is there. Very recently, last week only, April 14th, in the Lancet, there is an article that is Consort 2025 statement. They updated the guideline of reporting the randomized trials. So Consort guideline was initially introduced in 1996. There is an amendment in 2001, then subsequent amendment happened 2010. Very recently, last week only, the latest amendment happened. When you go to the Equator network or search online, you will not get the latest guideline for it. You need to refer to this particular article, and there are two parallel articles published by the same group of authors, Sally Hopel, Gary Collins, and the team, that is also published in BMJ and JAMA Psychiatry. So you can refer to that. I can share that article with the team. You can refer to that. This article gives an idea that there are some amendments, like previously when you are doing a clinical trial, you need to identify the criteria of recruitment of the patient group and the control group. Now you have to also, if you are conducting a clinical trial in multiple centers, now you need to also classify the selection criteria of the centers or the investigator who is conducting the trial. Suppose you are doing a tDCS related trial, then you need to say that the person who is doing the intervention should be having an experience of at least 1 year in doing the tDCS, must have delivered at least 1,000 sessions or 100 sessions of tDCS, must be experienced on a tDCS related training, or that institute must be having a tDCS related facility since this many years. So that you need to also narrate in the criteria. This is there in the Consort 2025 statement. So you can refer to this article for the latest amendment. The second article that says that when you are writing a protocol for clinical trial, you need to follow the spirit guideline of 2025. Previously, it was Spirit Guideline 2023. When they amended the Consort Guideline 2025, they also amended the Spirit Guideline of 2013. So now Spirit 2025 and Consort 2025 are in sync with each other. That is freely available in the Lancet article. You can refer to that. And at the end of this article, they have given a Annexure 1 and Annexure 2 that gives what are the changes that happened from 2010 to 2025 guideline. They did some 7 points are newly introduced. There are 4 points that are revised and 1 point was deleted. These are the modifications they did. Now, conducting clinical trial in India, the Indian Council of Medical Research, they have laid a guideline in 2017. There is a dedicated guideline for how to conduct clinical trials, how to do clinical trials in multiple settings, how to do a biological trial, how to do a device-related trial, surgical intervention-related trial. Everything is there in the guideline. You can refer to this guideline. It is freely available in the website. Now coming to CDSCO, I think this is the last slide I'm having. CDSCO is Central Drug Standard Control Organization. This gives, just like this is parallel to US FDA in India. So this gives approval to different modalities of treatment. It gives different modalities of treatment ranging from pharmacological intervention, biological intervention, somatic intervention, any surgical intervention, even the lifestyle related intervention, everything is given a approval by CDSCO. If the intervention is approved by CDSCO, then only you can do the trial of its own. You can do it as a clinical trial. If it is not approved by CDSCO, then you have to take the CDSCO approval first. Then you have to conduct the trial. Now coming to the psychiatry related intervention, if you go to the CDSCO website, they give a list of devices that are being approved by CDSCO for clinical trial. There is no psychiatry related device under the heading of psychiatry. The devices that are being used for psychiatric condition, they are put under neurology. Now you look for cranial electrotherapy stimulator. It is being approved for management of insomnia, depression, anxiety, and look for the evidence. The risk level is D. It means that there is a serious side effect, serious risk. They have given the approval with a serious caution. Level A is minimal risk, level B is moderate risk, level C is moderate to severe risk, and D is serious risk. For deep brain stimulation, they have given a category D. For electroconvulsive therapy, they have given a category C. Look, the funny thing is electroconvulsive therapy is having a category C, but cranial electrotherapy, which uses the stimulus, which is 200 to 400 times less than that are used in electroconvulsive therapy, they have given a category D. So this is the scenario CDSCO, and they are revising it from time to time. If you are using tDCS or transcranial electrical stimulation like TACS, tRNS, or TPCS, if your institute is asking for CDSCO approval, you can refer to this CDSCO document. You can show that CDSCO has already approved for therapy with caution. Now, summarizing that, we understood that why clinical trial is important, what are the types of clinical trial, how it need to be done in an ethical, moral way, and in a sound manner, and when it need to be initiated and when it need to be stopped. We have discussed about preclinical to different phases of clinical trial, and clinical trial has its own benefit and influences the clinical practice guidelines. It adds value to the evidences existing in the science. It is conducted in a very ethical and moral way. It gives the value to the innovations, whether the innovations are actually hypothesis behind the innovations are actually rational or not. That only you can check after a clinical trial. And you can also, through a pragmatic trial, you will be able to know that whether the cost is affordable by the major public or not. These are some important resources you can refer to if you are planning for a clinical trial. Thank you so much. I will be happy to answer if you have any queries. You can write to me in this my email address. Sorry, I took a bit more time than expected. I'm stopping sharing my slides.